Hello everyone and welcome to the next in our series of TRSP webinars. I'm Julia Lappin. I'm the Clinical Director for the New South Wales Tertiary Referral Service for Psychosis. I'm a clinician and a researcher working as an Associate Professor at the discipline of Psychiatry and Mental Health at NSW, and I have over 20 years experience working clinically and in research aimed at improving outcomes for people living with psychosis. I'd just like to begin with an acknowledgement of country and of lived experience. I acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people, who are the traditional custodians of the diverse countries from which we're joining this meeting. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation, and I pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families, or supporters. So welcome to the Mindgardens Tertiary Referral Service for Psychosis Seminar Series. The TRSP is a New South Wales Health funded statewide service hosted by South East Sydney Local Health District. I'll be providing the webinar today, and I'll talk a little bit more about the service and what we do, and also some of the outcomes and research that we have evaluated over the past 4.5 years of TRSP's running. Just a little bit of housekeeping before we start. As participants in the audience, you can write questions in the Q&A, but you won't be able to speak or be seen. And there will be a simple anonymous poll at the end of the webinar. Please complete it so we know how worthwhile the event was. I'll just move through now to talking about real-world research from the New South Wales Tertiary Referral Service for Psychosis. So what is TRSP? Well, as I said in the intro, we're a New South Wales statewide service, and we work with adult mental health teams across the state to improve the lives of people who are living with psychosis. We offer intensive and individualized therapeutic approaches for the individuals and their families and carers, but we also really work with the clinicians looking after the individuals to try and find recommendations that are deliverable in the setting. Typically, people who are referred to us have tried multiple service and treatment approaches over many years, often, unfortunately, without finding support that's truly helpful to them. But what we hope is that following an assessment by our team, we can make holistic recommendations that are made at a case conference which involves the referring team in order to conclude with deliverable interventions that are achievable and feasible. In terms of our operational criteria, we have a really broad scope. We will assess pretty much anyone with psychosis for whatever reason. If people need a second opinion, if they need diagnostic review, if there are people who have challenging and difficult to treat illness, such as treatment resistance. We don't work only with that group of people, but as you'll see in the data that I present later, in fact, a lot of the people we see do have illness that isn't responsive to treatment, and we think that that's probably because these are the people that clinicians most need help and support in working with. So TRSP was set up with a view to be able to deliver world's best practice in the diagnosis, treatment and prevention of psychosis, and to enable clinicians throughout New South Wales to have access to a service that provides evidence-based support to interventions that they can utilise in their clinics, in the community, in inpatient settings. Beyond the clinical service alone, though, we provide high quality training and education for clinicians, And really, this is a capacity building role, and the TRSP Webinar Series is an example of that capacity building. All the webinars are available on our YouTube channel through the Mindgardens website, so they have formed a very good resource for clinicians' ongoing training and education. We also hope to contribute to international research in psychosis, and we have completed a body of work looking at how best to improve outcomes for people with psychosis in the real world setting. And ultimately, our overarching goal really is to increase the capacity for the optimal care of people living with psychotic disorders. Because at my heart, I've been working as a clinician researcher in psychosis for probably 25 years now. And I feel strongly that there's much more that can and should be done in routine care delivery for people living with psychosis. So just to talk you through, anybody who might be a clinician in the audience thinking about making a potential referral, this is a flowchart which was developed by our team social worker, just to demonstrate the assessment process once a clinician refers. Step one, we start and the referral is received, and just to be clear, we're very accepting of really all reasons for referral, as long as the person has psychosis or query psychosis. We accept about 98% of our referrals. So once the referral's accepted and underway, our registrar and other members of the team gather information from the referring clinicians and from case notes, and then each member of our multidisciplinary team will conduct an assessment with the individual, whether by telehealth or face-to-face. And then our team comes together to have a formulation around what's really going on for that individual, both from a pharmacological point of view, but also from a psychosocial and functional point of view. And that's one of the real underlying tenets to our TRSP model, is that we are very holistic in approach. We're a multidisciplinary team. We work to a recovery model, and we really try to make sure that we improve, yes, people's clinical symptoms, but also their function, their community integration, and their quality of life. So following our formulation, where we develop putative interventions to propose at case conference, we then provide a summary of what we've found in assessment and talk with the treating team, the referrers, about potential next steps, recommendations. And only once we know what the treating team thinks is deliverable and reasonable to try in their setting, we'll make those recommendations and feed them back to the individual at a collaborative care planning meeting, where the individual gets to have input into those interventions. So for example, if we recommended clozapine, but the individual was 100% against it, then we would say, okay, well, you don't want to have the clozapine at the moment, but perhaps you can return to think about it at a future point. But we really do want to embrace the recovery model and be collaborative, both with the clinicians referring and with the individual, him or herself. And the final step then is the recommendation letter, which will include all the assessment outputs and the recommendations from all members of the team, including our neuropsych, and the psychosocial reports conducted by the occupational therapist and social worker, which are often very helpful for clinicians applying for NDIS packages. So I'm sure many in the audience will be familiar with the recovery model. I just wanted to outline that this is really core to what we do in our multidisciplinary team. We focus on assisting with needs and goals. We're not, yes, we will make a diagnosis, but that's important for monies and funds to follow an individual and for them to receive the care and support that they need through NDIS and other things. But when working with an individual, we tend to focus on needs and goals rather than diagnosis. And we absolutely consider pharmacological approaches, but we go beyond that too to consider psychological, psychosocial, personal support, and other supports that an individual may benefit from. So it's a holistic approach to care with recovery in mind. And this highlights that for many people living with psychosis, they don't report symptom control as being one of their priorities. Really, their priorities when asked are that they could have a job, live independently, be in a relationship, be part of a community, and yes, be minimally distressed by their symptoms, but often recognizing that symptoms won't completely go away, and ultimately to be able to achieve their goals. Another key focus for us at TRSP, which has evolved really over the past four to 5 years of operation, is that we have found that our involvement can be particularly valuable for individuals living in regional and rural services. And I'm sure anyone in the audience who works in settings such as that don't need me to tell you that, you know, often there can be teams which are very under-resourced, lack of medical input, lack of MDT input. And we have found increasingly that many of our assessments come from regional and rural LHDs. So just to give you some stats, about 25% of New South Wales population lives in regional and rural LHDs, but we get about 40% of our assessments from those areas. So that's proportionally quite a lot more than you would expect. And about half of our attendees at these webinars are clinicians employed in those settings. And I'll talk a little bit about our cognitive remediation therapy model, which is part of the research and implementation that we're conducting through TRSP. And we were very delighted when we got that research funded, because several of the 4 sites are actually rural and regional areas. That's Illawarra, Shoalhaven and Western New South Wales. So many of you in the audience may have attended some of these other webinars, but this is really geared at our role in capacity building. And some of the webinars, the most popular one to date has been the Trauma and Psychosis webinar, which was delivered by Sarah Bendel earlier this year. And she gave a great talk, which is really clearly of interest and value to clinicians tuning in. And we hope to keep the webinar series going over subsequent years of our operation. Okay, so that was just a little bit about who we are and what we do in the Tertiary Referral Service for psychosis. And now I'll talk about some of the research that we've conducted over the past few years. So I'll start just by talking a little bit about this idea of holistic recommendations. So going beyond pharmacological recommendations alone. We do, of course, provide second opinions about pharmacology, but there's a lot of evidence to suggest that people can get benefit from interventions beyond pharmacology alone. And that's what we looked at here. So you can see in this slide the reasons for people being referred to TRSP, and you can of course have many of these reasons. So the majority of people had high illness burden, long duration of illness, and about half had multiple complicating factors. To characterize the people referred, really they show marked clinical and functional impairments. So no surprise, over half had a diagnosis of schizophrenia and about a third schizoaffective disorder. mean age in the late 30s, majority male with treatment-resistant illness, and median duration of illness of around 16 years. So people have been unwell for really very many years, typically. High symptom severity, as shown by the PANS and the CGI, and very poor social occupational functioning, indicating major impairment there, with very poor cognitive functioning. So what do we recommend for people who are referred to TRSP? Well, in about 4 of 5 individuals, we will give recommendations about psychopharmacology, and that includes ECT. Everyone who is referred can be assessed by a neuropsychologist, and that often results in neuropsychological recommendations, such as perhaps chunking information for individuals, providing information in visual cue cards. I'll come to this later, but cognitive symptoms are often under-detected and under-recognized in people with psychosis, and it's extraordinarily valuable then to be able to offer the neuropsych assessment and recommendations, and we get a lot of feedback from clinicians about how helpful that is. Psychosocial support, really, these recommendations come from the occupational therapists and family workers assessments, which will often be utilised, as I said earlier, to bolster or apply for NDIS packages. We recommend psychological interventions in about 2 in 5 and can make substance misuse recommendations. They feature in about a quarter of people. And very importantly, we have a TRSP affiliated general practitioner who works in our service and provides a comprehensive physical health assessment of everyone and makes recommendations across a range of illness and disability issues, which again, treating teams find really helpful. Just to drill down briefly into the psychopharmacological and ECT recommendations, it's probably no surprise when we have a large number of people with treatment-resistant illness that if they haven't had a clozapine trial, or if they've had an inadequate, that is too low a dose or too short a duration trial of clozapine, we'll recommend retrial or dose change or augmentation with an augmenting agent. We do recommend ECT in about 1 in 10 people, but we don't mandate it. It's really only if individuals are on board with the idea of giving it a try, because ECT can be helpful for people who have treatment-resistant illness, either with clozapine or instead of clozapine. The only other thing to draw attention to in this slide is that we do see a reasonable amount of people who are on multiple antipsychotics, often without a real rationale, and have been on them for many years. So we do try to rationalize polypharmacy and try and get people on the lowest possible dose and combination of drugs to keep them well and stable. Physical health recommendations were made for pretty much everyone. There's a very high prevalence of cardiometabolic issues, so typical interventions would be to offer metformin, to refer to a diabetes specialist, to stop smoking, to try and engage in lifestyle and other interventions to reduce weight and metabolic syndrome. And this was a paper that was recently published in the ANZJP, which was led by our TRSP affiliated GP, Dr. Patrick Bolton, really talking about the ability that his role provides to see someone, albeit in a one-off setting. And that's what he refers to as commando care, going in, providing a really thorough, comprehensive assessment of their physical health needs at that time, and being able to provide treatment recommendations in that short window of opportunity. Okay, so that was an introduction to the type of people that we see and the type of recommendations that we make holistically for people referred. And I'll talk now a little bit about effective use of the interventions that we have. Before I do so, I'll just explain what I mean by a term I'm going to use through the next few slides, and that's the term complex psychosis. So really, that's a term for severe and treatment-resistant symptoms of psychosis with significant functional impairment. And these are people who are most likely going to require rehabilitation. But of course, many people who have complex psychosis can't access rehabilitation settings. And so many of us are looking after people with complex psychosis, either in the community or inpatient settings. And just to go over what we mean by the term treatment resistance, we really mean people who aren't getting an adequate response to antipsychotic treatment. They try one, that doesn't do much. They try another separately, and that also doesn't do much. And so that is the indication for thinking about clozapine. But it is very important to consider, alongside treatment resistance, also pseudo-resistance. Sometimes we haven't got the diagnosis right. For example, someone could have a bipolar disorder or extreme PTSD or OCD, and therefore they're not going to respond to antipsychotic treatment. And therefore they might look as if they're treatment resistant, whereas in fact, we've got the diagnosis wrong. Alternatively, we may not be providing adequate treatment, or the person may not be taking the treatment adequately. So, for example, we may have people on too low a dose of treatment. All of these considerations come into our assessment at TRSP and our subsequent recommendations as to whether people benefit or not from clozapine, ACT, and other treatments indicated for the management of treatment resistance. So I'll talk now about some data that was published in Frontiers in Psychiatry several years ago with several key members of my team there, my project officer, Kimberly Davies, colleague, Marianne O'Donnell, and my then psych registrar, Ishan Walpala. So we looked at all people who were referred and assessed by TRSP and who had treatment-resistant illness. And while clozapine is the indicated treatment for treatment resistance, less than half of people were receiving clozapine, though almost everybody had clozapine at some point in their illness course. Most people had continued to experience persistent symptoms while on clozapine, and clozapine plasma levels were rarely reported. The median clozapine trial was only 4 months. Now, this is really important because we know that clozapine is the best treatment we have for treatment resistance. But we can see from the people referred to us that individuals with treatment resistance are only being able to tolerate clozapine or being trialed on it for very short periods of time, with no plasma levels to guide whether they're on adequate doses. And so we don't really know if we've given clozapine a really good go, and if we had allowed people to stay on it for a longer period of time, ensured that they were taking it at adequate dose with good going plasma levels, then it may have been that we saw a response that enabled people to stay on clozapine and really to enjoy a much better quality of life. Of these treatment-resistant individuals, only 9 had trialled ECT. So again, that's a similar issue where we have an evidence-based treatment which is being underutilized. I totally agree that people shouldn't, if people have capacity and so on, and make a decision not to undergo ECT, that's completely reasonable. But there are many people who would give ECT a trial if they were talked through its benefits in the setting that they have treatment-resistant illness and very distressing symptoms. So the real take-home message from these slides are that there are a large number of people with treatment resistance who are currently underprescribed clozapine or have had who are no longer on clozapine and didn't have an adequate trial. So what we often encouraged was a clozapine trial or retrial or augmentation of clozapine or considering ECT. Ultimately then, treatments that work in New South Wales, these are all people in New South Wales who've been seen by TRSP, treatments that work, that like clozapine and ECT are generally underutilised. If you have individuals in your teams that you're looking after who you think might benefit from clozapine and ECT, but previously, for one reason or another, it just hasn't worked out for them, please do consider referring to us, because there are lots of ways to enable titration and uptake of clozapine. And if we see a clinical benefit, that can really encourage an individual and their families to push through and persist with some of the side effects that often lead to a very short trial. Okay. I'll just move on now to a related piece of work. So we looked at evidence-based treatments that were being underutilized in the pharmacological space, clozapine and ECT. We also, at the same time, were looking at the provision of evidence-based psychological interventions in New South Wales. So we know that there are psychological interventions that work for people with psychosis, and those include cognitive behavioural therapy for psychosis and cognitive remediation therapy, and more on that later. We went back and looked through the notes of all the people referred to TRSP and asked the question, how many had ever received psychological interventions? Well, in short, pretty much nobody. So no one had received cognitive remediation therapy ever in their illness, and only one had received CBT for psychosis. And this is a great shame because these are evidence-based treatments which are being utilised elsewhere in the world, but which simply aren't accessible here in New South Wales or in Australia more broadly. They're not provided as part of routine care at all, even if so indeed, one of the issues is, well, if we were able to offer them, how many people would be able to engage with the psychological work? And in fact, we found in the people that we assessed that around half were willing and had capacity to engage in psychological interventions. So what that means is that maybe not everyone can engage, but if we had them available, we'd be able to offer them to about half of the people that we typically see. And our summary from that work was really that we need better access to these treatments. As part of TRSP, we've really, aspired to achieve this through making recommendations through the clinical service and also through our cognitive remediation therapy program, providing training in the delivery of cognitive remediation so that clinicians on the ground can start to increase their confidence and knowledge of these therapies and deliver them in their setting if, of course, their supporting health district provides them with time and resource to do so. And that's a whole other problem with accessing these evidence-based interventions. I wrote about our ability in routine clinical care here in Australia to provide optimal care for people living with psychosis in this editorial in NZJP this year. Really what we know is that there are lots of treatments that work out there. Yes, we need research into new treatments, and certainly there are new antipsychotics in the pipeline which may help improve outcomes for some. But one of the big obstacles that we see in clinical care is that we can't access or we don't adequately and optimally utilize the evidence-based treatments that we already have access, that we already know about, like clozapine, ECT, CBT for psychosis, and cognitive remediation therapy. So this was really an editorial saying, can't we do better? Can we raise the bar? Can we introduce into routine care these treatments which we know can really help people both with their symptoms and with their overall quality of life? I'll pivot now to talk about cognitive remediation therapy, which is one of the evidence-based treatments that I mentioned is very helpful for people with psychosis. And we are really proud in TRSP to have been able to roll out a program of research for implementing cognitive remediation therapy over recent years. Just to set the scene, cognitive remediation therapy targets cognitive symptoms of psychosis. And these, as I said before, are often under-recognized in people with psychosis. But at least 70% of people with schizophrenia will have significant cognitive difficulties. And these include, but aren't limited to, poor attention, reduced verbal learning, reduced working memory, poor reasoning, and problem solving. In our current Australian and New Zealand college guidelines for the management of schizophrenia, it is recommended that everyone with psychosis receives cognitive remediation therapy and CBT for psychosis for that matter. But unfortunately, as evidenced in the work I just showed you and in other work that's been completed throughout Australia, we know that pretty much nobody has access to cognitive remediation therapy, until now at least. So cognitive remediation therapy, or COGREM, as we shorten it to, is a range of psychological treatments which are designed to improve cognitive abilities through behavioural training. And the aim here is, rather than improving scores in cognition specifically, it's more about improving people's function, real life function in day-to-day activities. So the rationale is that by improving people's ability to think through tasks and complete what's called metacognition, thinking about how to strategize, thinking about how to plan, that translates into real life so that they can better plan a visit to the bolo or get the bus to the shops and get all the items that they need in order to cook the meal that they proposed that they would cook that night. So these may sound like small gains, but I know to any clinicians working with people with psychosis, these are really big achievements to go from not really being able to do very much to be able to carry out goals which the individual sets for themselves at the start of therapy, to be able to complete those by the end of therapy. These are the real benefits that we see from someone engaging in cognitive remediation therapy. So we know it works. Lots of international work has been completed on cognitive remediation, showing that it improves cognition and particularly functional outcomes for people living with schizophrenia. This became our primary area of focus for improving outcomes for people with psychosis beyond pharmacology alone. So I don't deliver cognitive remediation myself. Our program of COGREM has been run over the past several years by Chloe Gott, who's our wonderful neuropsychologist in the TRSP team. Chloe got trained up in the delivery of a particular program of cognitive remediation called Circuits. This is all delivered via a computer model. I've shown a typical screen on the slide there. It's based around a town, and there are different tasks, for example, in the library, getting a bus somewhere, going to the shopping centre, etc. And again, it's around this idea of using strategies for thinking, metacognition, thinking about thinking. And consumer will typically engage in a program probably twice a week with a therapist present in the room. It can be one-to-one, or it can be in a group setting where the therapist is available to support people going through individual tasks within the circuits program that are tailored to that individual's needs. These are just some more examples of the computerized tasks that are available. And the tasks vary in the cognitive task that they target. For example, it might be attention, speed, working memory, executive functioning. So that's your ability to plan. And they vary in difficulty according to the individual's needs. So what we're trying for is people getting the answers mostly right, because that encourages them to keep going, but being stretched a little bit so that they're really starting to think about their thinking and to learn strategies. The therapist is present to help people approach the tasks, and also to think about how these new skills can be transferred, or what we call bridged, into day-to-day functioning. So how does learning to write a list to help you remember more items bridge into a real life task? For example, writing a list of what you need in your shopping for the meal that you want to cook tonight. And cognitive remediation, as we discovered during the pandemic, can definitely be delivered by telehealth. That has enabled us to support access for consumers living in rural and regional sites. More often, it'll be delivered face-to-face, one-to-one with the therapist. And that really is, you know, your gold standard, because that allows really highly individualized and responsive input from the therapist, who's providing feedback on everything that the participant is doing. But it can also be delivered in group programs, and the therapist can probably support maximum of 3 to 4 consumers at one time in that sort of group setting, when each individual is working on their own computer and the therapist is there supporting. Often, in fact, we'll have 2 therapists in the room to provide that function. And we got together as a group with the other people in New South Wales and beyond, particularly Francis Stark in Queensland, who's been a real pioneer for cognitive remediation therapy in rehab settings for people with psychosis, but also really the leader in cognitive remediation in New South Wales for many years has been Matt Thomas, who introduced a program of cognitive remediation at Bloomfield Hospital through his neuropsychology role there. And he really established a platform for cognitive remediation to start to take off in New South Wales. So we're very grateful for his work and his continuing collaboration with us. Together, we wrote this piece for the Australasian Psychiatry, really saying what we need now is not to test CogRem anymore. We know it works. What we need is to implement it, translate it into clinical practice. And we were very fortunate that all the people involved in this piece of work then got together to apply for an MRFF grant. And we were delighted when we heard earlier this year that the team has been awarded $4.3 million to implement cognitive remediation therapy in public mental health services in New South Wales and in Queensland over the next few years. So it just shows really that by coming together as a team of people who are passionate about a therapy and passionate about the changes that they see in the individuals who are provided it, that you can make change. And we're very excited to be gearing up to deliver cognitive remediation over the next few years here in Southeast Sydney, but also in Illawarra, Shoalhaven, far western New South Wales, and in the Queensland Health Service, where Prof Francis Stark continues to lead COGREM work. So, you know, we're proud that we're making cognitive remediation accessible. The steps that we'll proceed through are really to try to integrate the delivery of cognitive remediation into routine care, so that anybody who's cared for in a community mental health team could be offered cognitive remediation therapy, if they're willing and if it's likely that they'll benefit from it. The first step is to train up clinicians and to establish a supervision network for those people learning to deliver COGREM, and then to try and work with the LHDs and the executives to allow these clinicians, once trained, to have time in their day, in their week, time and resource to work with individuals in this quite intensive way to deliver the therapy that they're now trained in. Okay, so I've taken you really on a whistle-stop tour of some of the research that we've carried out to date, and I just want to finish on one final piece of research that we've conducted in TRSP around metabolic health and semaglutide, which some of you may know as the diabetes drug Ozempic. So this is a study that we rolled out over the past couple of years through the TRSP in our health district. And semaglutide is a drug delivered once a week in a subcutaneous injection, really into the tummy fat. It's been used in diabetes management for many years, but we were using it in this research study for people with psychosis treated on clozapine or olanzapine, which are the antipsychotics with the greatest associated weight gain. And we're investigating whether Ozempic can lead to significant weight loss in individuals with psychosis. It was also a feasibility study to an extent, because we weren't sure to what extent people with psychosis would engage in having a one-weekly injection, coming along to clinic once a week, being weighed and having their waist circumference measured. And there's also a number of side effects associated with Ozempic that we wanted to see if you know, our cohort, our population would tolerate. So here's some of the scientific information about semaglutide. It's a GLP-1 receptor agonist. Previously, it's been shown that it can result in that other GLP-1 particularly another drug called liraglutide, do work and can result in clinically important weight reduction in people with severe mental illness. And we wanted to try semaglutide because it could be even better. And we think that's the case because in diabetes research, we see that it works very effectively with greater weight gain than some of these previous drugs that have been tried. So we set out to offer a clinical trial where we had a research nurse, Jacob Hansen, working with us, and my research officer, Sarah Grattan, has really helped coordinate this study, looking at does weight change over time in people on semaglutide treatment for approximately 26 weeks. We also, though, wanted to look at whether any differences in weight were due to loss of all body tissue, or whether it was proportionally more body fat that was lost. And we examined that through DEXA scanning. And we finally have looked at the microbiome. So the microbiome I'll come to, but we wanted to look at richness and diversity of the microbiome, whether that was affected by people receiving semaglutide. And here's a table showing the characteristics of the population who took part. So you can see that 2/3 were female, mostly in their 40s, mostly Australian, and very high baseline weight of mean 107 kilos with a very large waist circumference. And what did we find? Well, of the 26 people who completed the study, the weight on average reduced by over 10%, which is absolutely huge. Even when we took into account, and that's the intention to treat analysis at the bottom, then even when we took into account people who had dropped off during the course of the trial, of whom there were 9, the weight loss was still 9.9%, so still very high. And here's a graph that just shows kilos dropping off over time over the course of the trial, which ran for approximately, each person stayed on for approximately half a year. In answer to the question about what type of weight do you lose, is it just your total body fat, or is it, what's happening with your lean body mass? Well, what we can see here is that there is a reduction in total body fat, so you're losing fat over time. But here, the lean body mass, as shown in the DEXA scan, if any, this wasn't a significant effect. We only had a small number of people. But what you can see is that actually the slope goes up over time. So people are, as they lose fat, proportionally their lean body mass is increasing. So people aren't losing protein and muscle so much, they're mostly using fat. And that's good news moving forward for use of semaglutide. And finally, then, just to talk a little bit about the microbiome. This was an innovative idea where we took the opportunity of having our population of people with schizophrenia being exposed to a new treatment, semaglutide. We said, let's have a look at what's going on in their gut. So here's a brief 101 to what the microbiome is. We all have lots of gut microbiota, and that can be bacteria, yeasts, viruses, and other things. They're all living in our digestive system, contributing to our metabolism and our immunity and lots of other things. There's increasing recognition that there's really very extensive bidirectional signaling between the brain and the gut and the microbiota. And disruptions, changes to gut microbiota can be caused by diet, medications. Antipsychotics are one of the worst offenders in disrupting the gut microbiota, but also environmental factors and stress. And we really wanted to look at semaglutide and see what's happening with the diversity of the microbiota. It's important to do this because it may be that changes in that semaglutide causes are mediated through the microbiome. We're really at a very early stage of understanding the microbiome and how it impacts, particularly in people with schizophrenia. So this was a first step in trying to better understand why some people respond to semaglutide while others don't. We haven't got the data in, very complicated analyses, but we continue to research in this area where we hope to have the findings of the change in microbiome for people who lost weight compared to those who didn't very soon. And this, we hope, will be the start of a real program of research to better understand the microbiome, gut-brain axis, and psychosis. Overall implications for use of semaglutide, and also known as Ozempic, in our population. First of all, it was safe, it was well tolerated, there were no major side effects. Many people did complain of nausea, many pushed through, some couldn't tolerate it and within 2 or 3 weeks withdrew from the study. Importantly, the primary aim was to look at decreases in weight and total body fat, and we saw marked decreases in both, while lean body mass was largely unchanged. So we can conclude that semaglutide from these pilot data is effective for weight loss, and it could be used in future in this population. It's not on the PBS for the indication of weight loss at the moment, but given that most people who start on an antipsychotic will put on a huge amount of weight, it may be that in future we could champion the idea that there could be co-introduction of an agent such as semaglutide at the time that an antipsychotic is commenced as a preventative measure so that people never really put on the weight in the first place. That's as yet a further piece of research work to be tested, but it would be a wonderful idea if we could stop the very high rates of metabolic syndrome and obesity in our population. So I'm going to stop talking now, but I just want to say a huge thanks to my team who've supported and worked with me over the past 5 years, both the clinical team listed here and our researchers, and also all the collaborators on the projects that I've talked about today, and there are many, many more also. I'd also like to thank our funders, including Mindgardens, New South Wales Health Sphere, and our philanthropic funders, and I'd also like to thank South East Sydney Local Health District for supporting the TRSP and our clinical research work. Here's the team as we currently are. And just while anyone might be writing a question into the chat, I'd like to just provide a little bit of information about next month's webinar, which is the final TRSP webinar for this year. And I'm really delighted that Professor Carol Harvey from the University of Melbourne is coming to present to us on the topic family inclusion and family work in psychosis. That'll be a great talk, and this topic was one of the those chosen by audiences of previous webinars as being most sought after. So delighted to have Carol with us next month. Just a final few little bits of information. If you want to get in touch about the Tertiary Referral Service for Psychosis, write to that email. We're really happy to discuss referrals informally before they're made. We really welcome contact with clinicians across the state. And if you want more information about the Mindgardens Neuroscience Network, information's there. Okay, so I'll stop sharing and we'll move to gallery. And if there are any questions in the chat, I'll be really happy to take them. Okay, so I've got a first question. How specific does the referral need to be to get input? Look, honestly, as I just said, we really are very keen to work with clinical teams and support them. That's our function. We see you as our consumer from that point of view. We want to work with you. We do have a referral form, which we can send you if you get in touch with us at that email address. There is a certain amount of information that we would like. If you don't have all the information to hand, or if you want to talk to us about it on the phone, we can scribble down the relevant information. And we would like to make the referral process as straightforward and navigable for you as possible. So please do get in touch. Okay, and then Justin in Illawarra, Shoalhaven has asked, if a 54-year-old male has been on clozapine for around 10 years, but still experiences psychotic symptoms daily, distressed by these, but has good functioning, can TRSP still offer him service? Absolutely. Please refer him. If he's distressed by his symptoms, there may be more that can be done. There's psychological interventions, there's psychosocial evidence-based treatments, a lot of which can be facilitated by an NDIS package and other resources that may be available to him by telehealth or locally. So yes, Justin, please refer. The next question is, do you have any ideas for how we get buy-in from evidence-based rehab approaches from the systems that we work in? It's my experience that we continue to work very much in a biomedical focused model. Yes, I completely agree with you. And that was actually really the essence of the editorial that I wrote, that I mentioned this idea of, can we raise the bar? I agree that, of course, pharmacological treatments are the mainstay of treatment, but there's so much more that we can do. There are lots of resources that we could be providing routinely in rehabilitation services, which sadly I feel we're hugely under-resourced to do. And I think that we need to come together as a community to really champion for the needs of people living with psychosis and for our ability as clinicians to provide some of these treatments. So thank you for that answer. Helen Graham has asked, what cohort of consumers benefit from this therapy? And I think by that question, you mean the cognitive remediation therapy, Helen. So that's a great question. So we were talking mainly about people with psychosis and people who have cognitive deficits. Many people with psychosis do. Typically, we wouldn't, typically, but not always, we probably wouldn't offer cognitive remediation to people who also have intellectual disability because it's not evidence-based in that group. But many people who have cognitive deficits and who are willing to engage can benefit from this treatment. Hope that answers your question. Sarah, thank you. Interested to hear if you have a carer peer worker in your TRSP. Yes. Sarah, for many years, we had a peer worker as a core member of our team, and that was a very valued role. The person who was most recently in that role was Kenny, who was part of our authorship on our paper about holistic recommendations, Kenny Lloyd. And he has moved on to another role. We are thinking of slightly reworking that position because it can be quite challenging for the peer worker to hear a lot of sort of a lot of the true to life histories of the illness course of some of the individuals. We're thinking about having a peer worker come in a more consultative way and to be involved in our implementation work and our capacity building. But yes, it has been a core member of the team throughout. I think I've got time for just a few more questions. Rahul Gupta has asked, was there a baseline assessment of microbiome diversity in patients? Yes, there was, Rahul. Yes, there was. We did. I didn't explain that adequately because I didn't have any results to show you. But yes, we did a baseline, and then we did an 8-week sample, and then we did an end of therapy sample. So we're hoping that we have more to say about that in a few months' time. Julia Mackay asks, what dose of semaglutide did you use in the trial? Were there any concerns with worsening clozapine-induced GI hypermotility? Actually, that was something that we really looked at. Julia, I didn't mention that, but we did look at mental state stability because we wanted to make sure when we were providing this new treatment, semaglutide, to people with psychosis, was it safe primarily? Was it going to cause wobbles in mental state? And we found no evidence for that. And therefore, for the many people on clozapine, those who did have transient GI side effects did not appear to have them to such an extent that it disrupted their mental state, thankfully. I'm just conscious that we have come to the end of time. There are a few more questions here, and I would be delighted to answer the questions offline. And we will certainly send the referral form to everyone as well as part of the email that we send out to everyone who's attended. So thank you very much for your attendance today, and thanks for your questions, and please do keep the referrals coming. Thanks everyone. Bye.